taking time for your health. The African American Wellness Watch. Trusted information for us, by us. Dr. Mike LeNoir and other experts from around the country and around the world have the latest on how you and your family can get healthy and stay well. It's time for the African American Wellness Watch.
Good health and welcome to today's edition of Black Health News Now with Dr. Mike and the Professor, Mr. George Pearson. We're going to try to bring you up to date on some of the things that are trending around Black health. So, Mr. Pearson, welcome to our program. Again,
thanks for having me, Doc. Welcome and all that kind of good stuff.
Actually, it's welcome to our program.
Okay.
All right.
Hey, it's always a collaboration. You know, we like leadership, though, so you're doing fine. What's going on?
Well, a lot of stuff going on. First of all, let's talk a little bit about the national situation. Certainly, it's pretty clear that that Secretary of Health and Human Services, Mr. Kennedy, has an agenda, and his agenda has to do a lot with chemicals. Some of it may be really relevant, but I think he's poised to test all the controversial theories. So let's start one more time so I can focus. All right. Good health and welcome to today's edition of Black Health News Now with Dr. Mike and the Professor, Mr. George Pearson. I'm going to bring you up to date on some of the health issues trending around Black health. And Mr. Pearson, good to see you again this week.
Good seeing you, Doc. Thanks for having me. Got a lot of interesting things going on. I think one, vaccines and where are we at with it? Where's the Black community at with it? What do you think?
Well, here's what I think. I think right now the Secretary of Health and Human Services, Mr. Kennedy, has some good ideas about chemicals, and perhaps he'll be able to substantiate his opinions with some science. The thing that bothers me the most, though, is that he's got a lot of controversial theories, and he's bound and determined to test those theories, possibly at the expense of the health of the nation. It's not all his fault, because if you look around, the resources that we need to stay healthy have been significantly cut at CDC, Health and Human Services, FDA, all of these places. And I'm concerned that the combination of his interest in controversial theories and the lack of substantive resources to keep our nation safe is going to be a problem. How say you?
Well, I think also is that, you know, we're in an era of lack of science, lack of education. That is the disbelief. And in the Black community, especially, we have a large level of distrust of vaccine and just overall government involvement. And that's been historically proved out. And that's a valid fear. What we need to focus on is that we've had a quality history of vaccines being productive, improving healthcare outcomes, and you know the pediatric numbers. You can tell us about that in terms of the outcomes and the decrease in just general problems. Now we're even seeing whooping cough come back. What's your thought about that?
Well, you know, my feeling is, look, when I first started practicing, we would see 60, 70 patients a day. We'd have at least 4 or 5 meningitises during the year, many pneumonias, and many, many more minor infections like otitis media, strep, and the other kinds of things. For those diseases for which we've had vaccines, they've cleared the office out. We get to 15 to 20 patients. That's kind of a big day for us now. So that I think people have to really understand that, you know, when you don't get your children vaccinated, especially, you put them at great risk.
And you at great risk, and elderly at great risk, and immune compromised at great risk. I agree totally.
Yeah, so they're at great risk. And I think, you know, I think that many parts of the nation would prefer you didn't get vaccinated. I mean, because obviously many of these pandemics that we see of common diseases that have disappeared ever since we started the vaccinations are in Black communities and communities of people of color.
So are you seeing those cuts in terms of, you know, as they start cutting these dollars, do you see the cuts in these kind of, early childhood immunization plans? Do you see, again, with this whole issue around tariffs, the ability to even get these medicines?
Well, yeah, I think that's a problem. I think there are lots of problems systemically when your National Department of Health is in the hands of someone who has not had the administrative experience or the scientific background or belief. I think we need to give him a chance. I don't think he wants to see children die, people die. And I think just like the tariff situation, it may be that he's going to have to change courses once he sees what
We're speaking of dyes. What do you think about this removal overall in terms of removing the red dyes because of their petroleum base? But the discussion is, if you do that, what kind of effect is it going to have on the industry, and do they have a replacement? What's your thought about that?
I'm an allergist, so we see some allergic reactions to red dye. I think that he deserves an opportunity to prove his case on that one. I don't have a particular opinion of it. I don't think substantive chemicals added to foods is a good idea. So I think I'll give him a pass on that. But we'll have.
I think for me, the discussion is, have these, and you would know the numbers better than I, have these dyes, and you see a direct correlation between the dyes and allergy and asthma and atopic dermatitis and reactivity in terms of allergy testing. What's your thought about that?
Well, I think it's difficult to say. We don't see that many patients for whom red dye is a solution to their clinical problems. But now we're in allergy season. Hey, this is a big time for allergy now all across the country. For those of you who don't realize it, that the different parts of the country have allergy seasons at different times. On the West Coast, we have a long allergy season from February through May, early part of June. On the East Coast, you have two allergy seasons, one for grass pollination and one for ragweed pollination. But it's grass season, so if you're wheezing and sneezing, it's allergy season. Unfortunately, most of the allergies this time of year can be handled by the relatively new over the last 10 years, medications that are across the counter. The antihistamines that don't cause drowsiness, and the nasal sprays like Flonase or fluticasone nasal sprays. And for those of you who get asthma during this season, certainly we have a new philosophy of how to manage most children and adults with a combination of long-acting beta agonist, which is like albuterol, in conjunction with an anti-inflammatory agent every time you take a spray. The most common of those is Symbicort. I could give you the scientific name, but why? I mean, Symbicort is what most of us refer to it. It's replacing albuterol not only for long-term care, but also for short-term care. Are you seeing a lot of allergy out there where you are?
What I was going to ask you about is this discussion around the different philosophy about allergy testing and how to make someone allergy-free from a product. It used to be that we tried to make sure the person stayed away from the offending agent. Now, I'd like you to talk about what is the philosophy now around slight exposures to these agents, as well as getting introduced earlier in a child's diet.
So now we're talking about food allergy, especially. I don't think that exposure to pollen seems to desensitize a patient. But we know a lot of things. But as you know, George, it's like what goes around comes around. When I first started practice, we used to feed infants cereal at 3 to 4 weeks, and then gradually introduce solids. Then came along the philosophy that it was harmful to the child, that a solid shouldn't be introduced to 4 to 6 months. And under those circumstances, then you'd have better outcomes. But now what we know about the immune system is the immune system is relatively immature when babies are born, such that if you give them a certain food over a period of time early on, then it protects them against allergy and enhances their ability to fight infections. And so now we've changed to start feeding infants early, especially those high protein foods like milk and egg, soy and wheat. Those are foods that tend to be more of a problem for children and infants. And so consequently, now we're back to feeding them early. And it seems to be much more effective. So I think it's a good question to ask. And there are lots of things going on in food allergy that we can talk about maybe at another time.
So I think I want to ask about the racial differences. And, and people of color patients to get in, to get allergy testing, to prescribe to the treatment, to really have an evaluation from someone like yourself?
Well, I think that that's important. I think that most of the time, you can, George, I want you to do two things. I want you to reintroduce that because I messed up and didn't have you on the screen. The second, thing, I want you to go to your settings, and where it says, you got it on blur, right?
Yeah.
Take it off blur.
Let's see the virtual background.
Yeah, well, take it off, or put it on none. Put it on none.
Okay. Okay, there you go.
See, now you're much clearer, and it's a much better picture.
Good. Okay, great. All right, we're good.
If you can
there you go.
If you can move your camera down a little bit so more of you is on the screen, that would help. Just tilt it down a little bit, up a little bit more, right there. That's perfect. Up a little bit, up a little bit. Up and up. Yeah. Okay. Okay. Now I can. Okay. Are you back? Are you back? Okay. Oh, you're on mute. You're on mute. Unmute. Unmute your microphone. Did you unmute it? I can't hear you.
There you go. How's that?
All right, that's good. Now move your camera down just a little bit. Down just a little bit. Down a little more. No, I want more of you in the screen.
Okay.
Okay, so there you go. Now that's perfect. And see, now we don't have that particular delay. And so we were talking about allergy. Let's start there. That's a much clearer picture. And then you're not delayed. All right, so let's go back and start where I think we had a good discussion on Kennedy. Let's just talk about allergy. Let's kind of stick to pollen allergy for right now. Because the food allergy thing is a whole different discussion. And let me lead you into that kind of discussion so we don't get off track. All right, so I'm starting again at 13. I don't believe 13 to me is a unlucky number.
So much for science and education.
That's right. Especially when it comes to, see, I was telling somebody the other day that right now, I'm fairly agnostic. But I'm sure near the end, I'm going to be grabbing from God and everybody. Everybody. All right, everybody hope, I heard. All right. Okay, good. 14. Good discussion, Mr. Pearson, about on the national issues. The thing that about the red dye, that's where we started, right? Yeah. So ask me the red dye question again, and then I'll lead it to the pollen question. We'll stick with pollen.
Well, Doc, aside about dyes, red dye, what has been your experience with this particular product? It's going to be removed from a lot of the foods. That's what the big push is for. Do you think it's going to make an effect in terms of allergy, asthma, atopic dermatitis, or whatever?
Well, George, it's interesting. I've had some patients through the years who've had allergy problems with red dye, but I'm more than willing to give the secretary a pass on this. He's got a lot of controversial theories he's got a chance to test. And I don't think he really wants to harm the nation, but I think that he will find out that some of the science that's already been done is relatively accurate. Red dye is probably not a good thing to have on foods. I mean, I just intuitively, I think that. I don't see a lot of allergy from it, but I do think intuitively taking it out or taking some of these additional chemicals that are added to food, out of food, probably does enhance the health of the nation. So I don't see much of it in allergy, and I can't evaluate the danger it poses to the general population. So just let's let him do his thing and see how it improves the health of the nation. But as long as we're talking about allergy, let's talk a little bit about pollen allergy. Are you seeing it out there?
Well, my best go-to is you when I'm seeing a person with cough and wheezing. Well, not necessarily cough, watery eyes, runny nose, itchy skin. It's almost invariably it's pointing back to now, just not seasonal allergies, but every season is allergy season. What do you think about that?
I think pollen season is special. Okay. And I blame you guys in primary care for taking food out of the mouths of the babies of allergies, because now there are a lot of good medicines out there to get you through the pollen allergy season. Interestingly enough, if you think about allergy in any community, certainly it impacts people of color more often, because in addition to allergy, you have pollution superimposed on that, and you seem to be a lot sicker group of people without access to either primary care or specialists. So they seem to be a little sicker in our communities. There are two seasons for allergy, pollen allergy on the East Coast. One is grass, the other is ragweed. On the West Coast here, we just have a pollen season that starts in February, goes all the way through mid-June with the trees pollinating first and now the grass. But there's some good products across the counter, antihistamines that don't cause drowsiness, like Zyrtec and Claritin and Loratadine and fexofenadine or Allegra. There are nasal sprays like Flonase, which is across the counter, used to be by prescription. Right. And then for patients who are wheezing a little bit, in addition to albuterol, we now have some long-acting combination medications, actually short-acting and long-acting medication, which combine the chemical that opens up the airway with a chemical that cuts the inflammation that causes the problem. So I'm telling you, I got to pull one of my children out of college because you fellas in primary care are taking all of the allergy patients and
hey, Doc, a question on the side. What do you think is the effect of global warming on the new allergy season? As I said before, it's supposed to be more prolonged. I talked to allergists, said that there's no, although you believe a couple of seasons, it seems like in general people are having these allergies, across the year.
Well, I think without question that when you have something like that, what happens for our audience is that when you have global warming, it changes the topography of countries around the world. So sometimes the deserts now might bloom, and when it's blooming, it might be deserts. I think that global warming with the oceans rising are going to take out some of these very high-risk communities. So I think that it's something that we really have to keep our eye on. Another issue, we should maybe move on from that now, is the issue of maternal and fetal mortality. We're starting to, there's a couple of articles in this week's issue of one of the major journals that talk about the impact of the Supreme Court decision against abortion and how it impacts on maternal and fetal mortality. There's no question, but in those states where abortion has been banned, you see infant mortality go up and maternal mortality go up. And so consequently, even though we had a problem before, we got a bigger problem now.
Well, I think too that in practice for me, when I first started in '82, women of color, particularly African-American women, were poor and lacked resources, were the majority of those dying from infant mortality as well, fetal mortality as well as maternal mortality. Let's fast forward to 2025. The difference is that the women are the same ilk and dying, but they have insurance, they're college educated, and some in the greatest shape in the world. I point to a woman, Tori Bowie, who is one of the Olympic medalists, who recently died in childbirth. So you can have insurance, you can have all these kind of issues. It says something internally about the system, internal and structural, that has put women to having issues in terms of bringing children to term and surviving the pregnancy. Pregnancy is not a safe event. I think we need to kind of understand that message, that when women get pregnant, they're putting their lives at risk.
Well, the other thing, though, is we'll be looking at these statistics. 25% more C-sections in African-American women. And much of the mortality of Black women comes after delivery because of the lack of attention, paying attention to symptoms and signs. And then when you were explaining it, there's an institutional racism against that impacts African Americans, people of color, in a way that
I agree.
That ignores symptoms that may be paid attention to other people. One of the things about this issue is that we have lots of talented Black professionals working on this issue. And hopefully we will start to bring those statistics down. But it doesn't seem like that's happening.
Well, in California, at least, there is a designation, and there how you study something to death, right?
Right.
In terms of
Right.
I couldn't resist that one. For our audience, the discussion around our problems are studied to death. They study until we die. So that's the plug on that. But the bottom line is, folks like California and states like California are leading the way in terms of having a whole program for infant mortality and having women and women of color in institutions kind of marry together to see why women of color are dying. I would say this: 83% of the physicians are white, 3% of the providers are people of color, yourself included. You cannot have that mix and not have a sensitivity toward that group that you're taking care of. If you don't have a sensitivity toward, it's like, you're coming to that visit and people don't like you. They disrespect you. And that does not provide for quality of care.
Yeah, I don't obviously it's not every physician. I mean, most physicians, I think, do the best they can do, but it's a system where the observation of African Americans and people of color and the impressions that providers have and the system has starts early on. And so consequently, by the time you get to the professions, some of these opinions about the Black patient or the patient of color is already ingrained and kind of unconscious and institutionalized. So I think that's when people have to learn to take care of themselves and be their own advocates and have navigators and all that. And I think that's a different discussion. But I do think
I want to say this publicly. I want to thank you for having this conversation at this point in your career, because you don't have to do it. Well, so I think it's really important that we have this conversation as a part of being leadership and a respected physician in the community. So thank you.
Well, thanks for that. But I think that any concerned Black professional would have taken the same position I've taken. In fact, I wrote an article many years ago called "Study to Death." I mean, what happens is, and I blame the scientific community, because the scientific community will study us and they'll reach these conclusions, but they won't change any policy. And so consequently, we've been studied as either underserved and that's not just a Black issue, but that's an issue for people of color and the larger population of white people who are underprivileged. They study.
Definitely. And here's the discussion too. That conversation has been elevated in the electronic medical record to social determinants. Right. But we know this from way back. You could take care of that diabetic foot or that asthmatic child, but if they went back to no food, no clothing, and shelter, you were seeing them again.
Yeah. Well, the other thing too, and what gets me is that you can treat a child or treat a patient, but if you treat that patient and you don't, it doesn't change your style of practice, then I can't wait for social determinants to be taken care of. And that's what my message to our community is. Of course, social determinants are important, but when you need penicillin or cancer medicine, you need the medicine. If we wait for somebody to give us food security,
they'll sting you to the study that says you need it.
If we wait for somebody to reduce violence, take care of his food insecurity, housing and all of that, then we don't give people the proper treatment and medicine at the point of contact, then we're going to lose a lot of people who are
which brings up in my brain in this whole issue, it has to do with a lot of trauma. Mm-hmm. And how do you, as a practicing allergist, deal with those day-to-day traumas and care in terms of whether it's access to a medicine or telling a person about a diagnosis? How are you handling trauma now differently than you did when you first started practice?
Well, I think when I recognize when I see a patient is that you have to comfort that patient and they have to believe in your competence. And so I know I've been in practice a long time. So when people present me with series of symptoms, I pretty much know about what's going on. So now I have a different job. That is to comfort that patient, instill in that patient a sense of confidence that I know what's going on, give them an explanation of what I plan to do, and offer them either my home phone number if they're having a more serious problem. I mean, my cell phone number, if they're having a serious problem, and make sure they have a follow-up appointment. And
So,
so,
Doc, and it gets me again, you can add on to that, that you are engaged in intergenerational care. And in your practices, I've been there, what I find your patients saying is that you've taken care of the mama, you took care of the granddaughter, you took care of the, it's intergenerational care. And with that kind of consistency, you create a practice that, that your path basically because of that intergenerational care. Could you tell me a little bit about that and how you developed that?
Yeah, well, that means I'm old. That's what you're saying. You're saying that I'm old. I think, but here's the thing about care in pediatrics, man. If you don't talk to that grandmother, you're in trouble. I mean, you can do everything that you want to do. You can say everything to the parent, but if you go against the advice of that grandmother, you got a problem. So always try to figure out where the external information is coming from, so I know how to kind of deal with that. Now you're right. In many instances, I took care of the grandmother, so you're right. I do have an opportunity that's different from maybe some other pediatricians, and I'm actually grateful for the community clinic that I work for, community system lifelong, because it gives me an opportunity at this stage of my career to make certain that I'm providing care for that group of patients who need it the most. And so for years, I had a kind of a very large practice with a potpourri of people. But now I'm taking care of most people who, for some reason or the other, use the community clinic system, which in our area is really pretty good. Lifelong has been really good about allowing me to care for these patients, and I appreciate that. But I think to go back to what we were talking about, if you, as a physician, don't look at other things beside what the diagnosis is and what the treatment is, I think you do that patient a disservice. So let's finish our conversation with where we are with some of those chronic diseases. Chronic diseases like let's talk about hypertension. Let's talk a little bit about obesity and some of the other things. And cancer. In hypertension, 61% of Black women and 56% of Black men aged 20 years and older have high blood pressure. And is that what you're seeing in your practice?
For hypertension, and I think the biggest issue is that, but the majority of the conditions that you've just mentioned are asymptomatic until they hurt you. So,
George, let's start that conversation again.
Okay.
Because I kind of messed up.
All right.
All right, and let's update our audience this week on some of the chronic issues. Let's talk about three: hypertension, obesity, and diabetes. And for those of you who don't know, the professor is one of the Bay Area's best known family physician's assistant, and in our area, physician's assistant and physicians pretty much on the same par in terms of the number of patients treated at MASH. I wanted them to know why I'm calling you the professor. But let's start and talk a little bit about chronic disease. All right, let's start at hypertension.
I think. Go on, Doc. I cut you off. I'm sorry. Go ahead.
Let's talk about let's finish this week's discussion on our update on chronic diseases and minority communities, especially the African American community. Let's talk about three things: hypertension, obesity, and cancer. So let's first start with hypertension. It seems like it doesn't seem to be decreasing in our community.
Well, it's because it's not, and I think what we're doing now, we're better at identifying it and identifying it earlier. I think the misconception is that if something doesn't hurt you or kick you or slap you, it's not affecting you. Well, the diseases that you mentioned are all asymptomatic. Hypertension is asymptomatic until you have the stroke or the heart attack or you die. So we want to get in early, and we want to develop treatment plans early. I do a non-drug treatment for the first 3 months, which is total lifestyle changes. We incorporate the DASH diet, which is a plant-based diet. We incorporate exercise, we incorporate weight loss. And if then the blood pressure is still not normal, and that number should be 130 top number, 80 bottom number, then we look at instituting medicines. Usually for African Americans in particular, they do better on diuretics, water pills, and calcium channel blockers, drugs like amlodipine, calcium channel blockers, water pill, hydrochlorothiazide. And that's because we tend to retain a lot of salt and water, and it raises our blood pressure. It is a killer. So we want to ensure that it, not only just a killer, it's an in-organ damager to the brain, to the eyes, to the heart, to the kidney, to the penis, to the legs. That's why we want to treat it. And women in particular are underdiagnosed and undertreated. So that's a new population for me that I'm seeing now. And I think it's because of the insurance. More women of color have insurance.
Well, that kind of leads us into our next discussion. It looks to me, as I wander around the Bay Area, it looks to me like we are losing our battle with obesity. And I think much of the focus on changing lifestyle and watching diet has been replaced by these new drugs that are available for reducing appetite and weight loss.
The GLP-1s and stuff like Wegovy and Ozempic. These are the drugs, the cardinal drugs that use the GLP-1, and what they do is just basically reduce your appetite and allows you to lose weight.
Well, how are you using them?
I don't myself prescribe them personally. I let the endocrinologist service does it, but I'm really familiar with them. But because the same battle with the weight is the same battle with weight, obesity is the same battle with diabetes, poorly control is the same battle with hypertension. When you can have people lose weight, it tends to make the hypertension better, tends to make the diabetes better in terms of reduced disease burden.
So it really is a drug. Most people lose sight of the fact that it's really a drug for diabetes.
Exactly.
Exactly. Blood sugar. But it also is a part of that. Have there been some pretty dramatic weight losses? What about your experience? Have there been side effects from these drugs?
Well, again, these drugs are particularly primary for diabetes, but they have a indication to reduce heart risk factors. Cardiac risk factors. In other words, when you take these medicines, you reduce your risk of heart attack and stroke as a global piece. My point of it is that if you're not engaged in the lifestyle changes, then these medicines don't work as best they could. So, in other words, if you stop the medicine, the weight comes back. So it's not it's really interesting. I'm kind of understanding. People think that when they take a pill, it's supposed to last forever, but that's not the case. And if they're not doing the things in terms of total lifestyle changes and exercise, then they don't maintain the gains. This is a quick need society. We are a quick need society. We want things quick. And there's no suffering. There's no pain. Like our current commander, she said, we've got to suffer a little bit. So people don't want to do that. So these drugs are also engaged in a fight in insurance because insurance does not want to pay for it. In fact, if I'm not mistaken, American medicine still doesn't define obesity as a disease.
Yeah, well, that's certainly unfortunate. At last count, it contributed to almost 241 medical issues.
Oh yeah. But again, it's I have to say it's the power of the dollar. The insurance companies don't want to cover these drugs. Right. One, because it'll reduce disease burden. If you got people that have less weight, then there's less blood sugar, less blood pressure, less out-of-pocket costs. Makes sense to me, but they want that train to keep running.
Yeah. Well, I think that this has been a good discussion of what's going on this week. Every couple of weeks, we'll come together and kind of review what we think are important topics. I think it's important for the Black community to know that there are very few sources now for information that's transparent, that's relevant, and that's always true. And so we hope with Black Health Now that we'll be able to bridge that gap between what people need to know and what they actually get to know. And so, any final thoughts throughout this week?
Well, I would say stay happy, stay positive, turn off the radio, turn off the TV, take a walk, love and hug your family members and friends. Try to stay peaceful.
Man, you in a big Unitarian mood this week. That's all. I'm Dr. Mike, and this is the professor, Mr. George Pearson. We'll be back again in a couple of weeks.
Tell Miss LeNoir I say hello.
No,
Hey.
we can't do that. I gotta change that again. All right, let me remove you from the screen. All right, well, that's takes care of this week. We want you to appreciate the fact that we're constantly watching for information that you might need in any community, not just the Black community. Most of these issues we talk about are relevant for all communities. So for myself and the professor, Mr. Pearson, remember, health is your biggest asset, so protect it.